Okay, dear colleagues, thank you very much for inviting us, me as the representative of the University of Saarland. I just want to present to you our experience with short term actually, and now we're planning to make follow-ups on long-term preeclampsia cases. I'll just show you something which is a little bit unethical. We have the life cycle of a patient in our field. She gets delivered. The first encounter is with HPV vaccination, then follows the pap smears, then she becomes pregnant. Our patient again, she delivers, whereby she gets other patients, and then we have again pap smears, abnormal uterine bleeding, and mammography later on. I want to analyze this a little bit more because there is much more here to analyze than rather just sitting or passing this patient further towards the next step. So,
I would like to it's so funny.
So we decided to make or to do a prediction of the short-term postpartum maternal outcome in preeclamptic patients. We know we don't know. Now we know. So we know from a lot of studies, a lot of things about preeclampsia during the prepartum periods, elevated the SVP-HF ratios. The ratio correlates with the degree of preeclampsia. We can predict the management is still delivery. Not well studied is the prediction of biomarker, the prediction of postpartum courses in the short and long-term intervals. In postpartum courses, we know that the patient may develop HELLP syndrome in a significant amount of cases. Eclampsia, it may worsen and it may improve. The predictive test until now does not exist in the routine and is still a matter of studies. So, what did we try to do? We tried to predict the short-term outcome in the first 4 days and 6 weeks after delivery. Why did we do that? We wanted to decide whether this patient should enter the intensive care unit after delivery or pass to the normal labor ward, or receive, for example, a prophylaxis against eclampsia, or has the antihypertensive measure intensified prophylactically. So, and then we wanted to pass through the short-term observation towards the long-term observation, which I will tell you later. Well, we made a prospective observation of our cohort of preeclampsias, 30 patients over 3 years. Normal inclusion criteria of diagnosis of preeclampsia in between 23 and 31 weeks. Signed written consent. The patients have to be above 18 years old. We defined also the mild and severe preeclampsia as defined by the Society of Hypertension in Pregnancy. By exclusion criteria, we had to have the absence of the before mentioned factors, apparent limitation of psychosocial status or language barrier, no written consent, smoking, or other maternal pathologies like diabetes mellitus. How's our working protocol? Immediately prior to delivery, we diagnosed the preeclampsia. We signed the consent. If she is above 18 years of age, we recruit the patient, and then we do the SVP-HF and routine lab and clinical follow-up. She delivers. We have now a biobank. I took the idea from my colleague sitting here in the front, and we conserve the placenta and cord blood for other studies later on. And then we have the first postpartum follow-up, which is 2 hours after delivery, just in order to find out what happens immediately after delivery, if you have any biomarker that can predict the course in the later setting. And then we make further analysis of SVP-HF and routine laboratory parameters at day 1, 2, 3, 4, and week 6. And of course, the daily, normal daily routine assessment of blood pressure, weight, subjective symptoms like visual, neurological, and gastrointestinal symptoms. The results were quite expected. We had normal numbers. It was more like preterm deliveries, more IGRs. An outcome, of course, which is comparable to the normal, which is worse than the normal outcome without preeclampsia. We had 6% of the cases were severe preeclampsia. We are a referral center, that's why we get most of the severe preeclampsia with preterm labor. 50% of the postpartum course was unfavorable, and the results were quite. We did not want that, of course. We wanted to see a correlation, but we did not see a correlation of worsening or improvement by biomarkers. We had, though, a persistence high PLGF and sFlt1 levels, and they one correlated with decreased renal functions. We had elevated sFlt 2 hours after delivery correlated with increased liver enzyme levels. However, these were very sporadic and sporadic results. So we decided to continue the pregnancy as we assume that there are different pathomechanisms with different forms of preeclampsia, whether there is an added IGR, an added HELP syndrome, and so on. And we decided to extend more cases in order to make a more definite subgroup analysis. The more astonishing result was this, the participation. So they have the patients here in our labor wards. Sometimes we miss the sample, so we see between 28 to 30 cases. We always have the data. At day 3, we discharge most of the patients that get well very, very quickly, which is actually not okay. And what astonished us is the comparison between day 1 and week 6, where actually the patient did not want to hear about us anymore. They were less than one-third of the patients came at week 6. They did not go to their general practitioner and were not interested about the long-term outcome anymore. I'm talking about patients that were lying in the intensive care unit, patients that had severe symptoms. And most doctors claim that they counseled about long-term risks of preeclampsia, yet when we called the patients, they were not counseled and they did not have any idea about the whole thing. So I went back to the literature. I was a little bit disappointed, so I went back to the literature. I started reading again, and I saw these astonishing articles about the long-term outcomes of preeclampsia, and concerning the cardiovascular outcome, and concerning the development of hypertension. Many studies, I don't want to lose your time in this, and we saw, for example, four times increased risk of cardiovascular disease, hypertension, fatal and non-fatal ischemic heart attacks, stroke, thromboembolism, many complications that complicate further life, not just cardiovascular events, but also diabetes that develops later on in life compared to normal pregnancies. Very exact trials and studies about that. One cannot dispute them. These data are actually things that are not explained to the patients at all by obstetricians. So, and also, of course, also the increased risk of end-stage renal disease, as stated here from the registries in Norway. So, I was talking to Professor Arabi about that, then she told me, okay, I wrote something, read it, and then we'll discuss it again. So I read it. Of course, it's a summary of a lot of literature stating the increased risk of cardiovascular events, thromboembolic events, and other diseases complicating the maternal life and the neonatal life. So this is what we have in our guidelines. We have to present those patients to a general practitioner 6 to 12 weeks after pregnancy. This does not happen efficiently like I showed you. Only 33%, less than 33% are there. Blood pressure has to be assessed, renal function has to be assessed, thyroid function, diabetes, counseling on long-term prognosis. Some internal medicine specialists do not know anything about that, and even pediatricians have no idea about this topic. Normal pediatricians, of course, those in the university are different; they have an idea about it. And there has to be a yearly presentation at her general practitioner. This is stated in our AWMF guidelines. We have also these interesting studies that state that there are arterial changes in fetuses or ex-fetuses with intrauterine growth restriction, indicating that we have a long-term complication even for this fetus, and even this rule of 30 years, and then we have increased problems applies to the newborn too. So that we are faced with a lot of questions to be answered. How can we create in Germany a proper postpartum follow-up system and create proper awareness? We do have a problem that we cannot follow up children from their mothers because the registers in Germany are different than in Norway, for example. We know the gestational age of onset of preeclampsia determines the long-term outcome. yet we do not know still is the duration of pregnancy with preeclampsia a determinant factor for the long-term outcome for the fetus and the mother. We do not know the role of biomarkers in long-term outcome. We cannot know it because it's still very new. There are other things that can be followed up, like long-term follow-up of internal thickness, newborn and the mother, biomarkers, proteomics, economics. My colleague has a lot of things to offer in that field. And of course, this population has to be analyzed for pregnancies of second generation and third generation. So our suggestion is now to go and follow up long-term postpartum maternal and neonatal outcomes in Saarland, where we are. Our steps that we did already, we created a biobank to store the patient data, serum and placenta. We are doing now retrospective database dating 50 years back. We found them in our archives. In Saarland, we have a law that by which we have to keep the registries of the delivery for 30 years. And the remaining 20 years that we found in the archive of the federal state of Saarland, by which we can analyze further pregnancy after 50 years. We are doing this. There are two work groups working on this now. So our aim is to change it a little bit, and we are working together as the Department of Gynecology and Obstetrics with the internal medicine, trying to move the medical certificates in Germany because they have the say actually in the medical market, like we call it, and these are the Berufsverband der Frauenärzte is the collection of all doctors working inside the clinics that we are also trying to move, and they responded. They are okay to that.
Out.
Outside the clinics.
Out. Polyclinic.
Politics, exactly. Yeah. Also, we're trying to move the politics a little bit, and we have a lot of friends in Saarland. Saarland is very small, so we have the advantage that if you know one person, you know all of them. Okay. So we can affect somehow the decisions made in the government and made in the local parliament, as well as the society where I started to talk to the people in charge, and they're quite okay with that. In order to collect the information from all these hospitals and have a data extraction that can lead to a construction of a registry in Saarland. So we can change this life cycle again from delivery, HPV vaccination, pap smear, pregnant, delivery. We screen for long-term pathologies. We have better data, and we can do it. There are a lot of studies, and I think the speaker after me will talk about that. Long-term interventions by changing the lifestyle, for example, which can lead again to a better screening in the next pregnancy. Most of the patients that we see in our preeclampsia department are not. They are sent very late. They do not receive aspirin, for example, even though the effect of aspirin is very controversially discussed. Yet they have no idea about any screening programs or any follow-up programs that they may have to undergo. And so we kind of interrupt the cycle, or we maximize that cycle a little bit more in order to take care more of our patients, which is like the publication of Professor Arabi said, it's a window for future health. So it's a long way, it's a lot of challenges, and I hope I can benefit from your experience here now in order to improve this for the future. It's going to take 30 years, so I think we have a lot of time. Thank you.